So this is actually kind of a complicated topic, believe it or not, but I'll try to get through things in time for questions. This works. So the objectives or the key things that we're going to try to talk about today about heart failure is what's a heart failure exacerbation, why people are predisposed to having heart failure exacerbations, and then treatment. So what the initial approach to treatment is, the role of diuretics, the role of beta blockers, and some things about the role of renal dysfunction. Disclaimers. So this is more of a real-world heart failure lecture. This is not really board material, and you'll see why, because a lot of this stuff is kind of vague or controversial or physician-specific. And you'll probably hear things that are completely contrary to things you've heard in the past about heart failure management. So what's acute decompensated heart failure? So there's a few ways to think about it or try to organize your thoughts. So we see heart failure usually either as a new presentation of a disease or as an exacerbation of a chronic heart failure state, with probably exacerbation of a heart failure state being the more common reason that patients come to the hospital in acute heart failure. And so if you think about what heart failure is as a definition, right, the classic definitions from way back is the inability of the heart to meet the metabolic requirements of the body, or the ability of the heart to do that only at very high filling pressures. So those are the two things that could go wrong in terms of causing acute decompensated heart failure. So one of them is that patients present with acute dyspnea because they have elevated filling pressures for some particular reason, and we'll talk more about why that happens. Or the other reason is the heart is just not able to pump enough liters per minute, which is patients who present with heart failure in a low output state, so things like cardiogenic shock. This is actually incredibly rare. I'll show you the vast majority of heart failure that you guys see in terms of acute decompensated heart failure. So patients who come to the ED emergency room with dyspnea are patients who have elevated filling pressures as their main pathophysiology. So I think most of you guys have probably seen this warm, wet, cold, and dry slide, but this is really important when you think in order to try to risk stratify patients and try to figure out what exactly is going on with them. So the boxes are to try to figure out whether somebody is dry or wet and whether somebody is cold or warm. So what do these terms mean? So the wet part here is congestion, is whether you're congested. So how do we define congestion, or how do we think about congestion? So these are things like elevated filling pressures. So by physical exam, it's really hard to tell, the left-sided filling pressures by exam, but we use the surrogate of the right-sided filling pressures, which is the jugular venous distension, or hepatojugular reflex, which is sort of like a surrogate or corollary to jugular venous distension elevation. You could use peripheral edema. You could use potentially whether somebody has an S3, so extra hard sounds. Things like dyspnea on exertion or shortness of breath, things like orthopnea or PND. So just to define those terms, so orthopnea is really an inability to lie flat because of shortness of breath, and PND is the need to wake up in the middle of the night with shortness of breath. PND is exceptionally rare, we see a lot of patients with end-stage heart failure. PND is an exceptionally rare finding. So somebody who just wakes up in the middle of the night to go to the bathroom and gets a little short of breath, that's not PND. PND is people who wake up gasping for air in the middle of the night and have to sit inside of the bed in order for those symptoms to improve. Also signs of congestion on chest X-ray or physical exam, or potentially recent weight gain. We'll talk a little bit more about the weight gain. So these are probably fairly easy to tell for the most part. Typically, patients will have lower extremity edema, shortness of breath, and rales and chest X-ray findings of congestion. So congestion is usually pretty easy to tell. The cold or warm is actually much more difficult to tell. So cold refers to whether or not there's evidence of hypoperfusion. So the heart is not producing an adequate liters per minute of flow. And so the body responds to that in a variety of ways. So things that potentially are signs and symptoms of hyperperfusion are things like cold extremities, although kind of a lot of people have cold extremities because they have peripheral vascular disease or for some other reason. Low urine output, which is kind of difficult to ask somebody, how's your urine output going? Altered mental status, potentially inadequate response to diuretics, although you wouldn't know this for some time. And then other things which I think are more frequent and more important and easier to recognize. So nausea is an ominous sign of heart failure. If somebody comes in with heart failure and they're nauseous or they're throwing up, that is very high risk for patients not doing well. That's often accompanied by elevated liver function studies. So if your bilirubin, AST, ALT are elevated, that's significant evidence of both congestion and hypoperfusion. In terms of inadequate response to diuretics, so rising creatinine in the setting of adequate diuretic use is a concern for low cardiac output. Low pulse pressure is concerning for low cardiac output because pulse pressure is a surrogate of stroke volume. So those people who have low stroke volume are quite likely to have low pulse pressure. And then markers of hypoperfusion, which in addition to LFTs could be elevated lactate. So these things really should be evaluated in every person with acute heart failure who is at all unwell. A lot of patients who present with heart failure are actually quite well. They just come in with a little bit of extra volume, a little bit of shortness of breath. But patients who manifest other signs or symptoms, particularly these, are particularly concerning. Definitely cardiology should be involved in anybody who has heart failure and elevated LFTs or nausea. In terms of nausea and elevated LFTs, we very commonly see in our patient population, patients who have abnormal labs, whether in clinic or in the hospital. And the first line of thought that physicians have in these patients is that they have gallbladder disease. So patients will get an upper extremity ultrasound, they'll have a HIDA scan. These are likely to be abnormal in decompensated heart failure because of congestion. So the gallbladder will swell. You potentially could have some evidence of early cholecystitis. And so what will happen is these patients will go to the operating room for cholecystectomy, and then they crap out because they're actually in cardiogenic shock. We see that quite frequently, actually several times a year. Do we see cholecystectomies for patients who are actually in cardiogenic shock? So what does heart failure look like? Because I don't want to make it seem like everybody, again, who has heart failure has cardiogenic shock, because the vast majority of patients do not. So this is data from large registries about how heart failure presents, and this breaks it down by whether patients have heart failure with reduced systolic function, so a low ejection fraction by echo, or preserved systolic function, which is normal ejection fraction by echo. So systolic heart failure, and what some people call diastolic heart failure, or probably heart failure with preserved ejection fraction, is the more accurate term. And you can see these are very large data sets of like hundreds of thousands of patients. So this is pretty representative of what we clinically see. And these are patients who come essentially to the emergency room. So what do we see? So the majority have some lower extremity edema, they have rails and chest X-ray. The majority of patients who come in with acute decompensated heart failure are hypertensive. Okay? If you see somebody who has heart failure and is hypotensive, that is concerning. The vast majority of patients are hypertensive. Their average blood pressures, whether you have reduced ejection fraction or preserved ejection fractions, are elevated. So they're in the 140s, 150s. And you could see a significant percentage of patients are actually much more hypertensive in the 180s. Most of them have abnormal renal function, so elevations in CME creatinine. Most of them, and a bunch of them have dyspnea. But essentially, people come in because they're a little short of breath, they're hypertensive, and that is the typical presentation of patients who you see. And notice how similar these are between patients who have normal ejection fraction, patients who have reduced ejection fraction. The majority of these patients present very, very similarly. So potentially what this means is that you don't have to rush to get an echo as the first test to figure out whether they have normal or abnormal systolic function, even if you don't know that, because, again, they present differently. They present similarly, and the management in the initial period, as I'll show you, is actually pretty similar. This is another slide to sort of demonstrate, some similar things. So while this says important findings in chronic heart failure, a lot of these people with chronic heart failure will present acutely. So dyspnea, fatigue, palpitations, potentially anorexia or weight loss. With things like fatigue, anorexia, and weight loss, more suspicious of patients who have low cardiac output, but not necessarily. Syncope is obviously a concerning sign of heart failure. S3, cool extremities. Again, hypertension more commonly than hypotension, and then narrow pulse pressure. So seeing these things in the setting of heart failure suggests both potential decompensation on the outpatient setting or how you see patients actually present on the inpatient setting. So unlike most heart failure cardiologists, I'm not a huge fan of the physical exam, which is probably kind of surprising because I think most of the cardiologists who you guys round with, including heart failure cardiologists, especially those who were trained a while back, are very into the physical exam. Oh, did you hear that S3? Well, maybe I did, maybe I didn't. Hepatojugular reflex. Did you wait long enough? By the way, hepatojugular reflex, if you do do it, it's actually not the immediate rise in your jugular venous pressure. You actually have to wait at least a few seconds for things to normalize before you could say the hepatojugular reflux is present. And the reason that I'm not a huge fan of the physical exam is because there's a lot of data that the physical exam is actually quite limited. This data is largely from the ESCAPE trial. So the ESCAPE trial was a large randomized trial where they took everybody with decompensated heart failure and it was randomized to SWAN-guided care versus non-SWAN-guided care. And so it was done in experienced heart failure centers. There's a ton of phenomenal data that's been published out of that trial, and I'll show some of that data later as well. But one of the things they did is, they tried to correlate SWAN findings with physical exam findings done by experienced cardiologists. And so how do they do? You can see from this, not that well. So this is for the two things that are kind of important. One is whether or not you can identify patients with elevated filling pressures, in this case of wedge pressure, which is left atrial pressure or left-sided filling pressures of more than 22, or cardiac index of less than 2.3. And usually cardiac index of 2.2 or below is part of the diagnostic criteria for cardiogenic shock. So this is whether you could diagnose elevated filling pressure and cardiogenic shock. So an S3 has about a 50% sensitivity, specificity, positive and negative predictive value. So whether or not you do or don't have it, this means that either one, cardiologists are not adequate at picking up what an S3 is, which it's probably highly unlikely. These are probably more experienced cardiologists, or that it's just really not that great. Even JVP is not that great as a predictor, again, either because we're not doing it accurately enough or because it's really just not that great. Rails, while specific, are not sensitive. Orthopnea, the other way around. Even things like peripheral edema that I'll mention in a bit, is really not that sensitive or specific, and the positive and negative predictive values are pretty suboptimal. It's kind of the same for low cardiac output, which is why identifying, that cold profile in terms of the boxes is fairly difficult because you can see the sensitivity, so it's only present in about a third of the patients. Low blood pressure, not present that commonly. Low pulse pressure, while these things have high specificity, for one thing, they're not even physical exam findings, but have pretty low sensitivity. The one thing I will point out that I think we use clinically is rest fatigue. So people who are tired at rest are very likely to have low cardiac output, but that's the case either on the inpatient or outpatient side. And again, that's not really a physical exam finding, right? That's more of an that's more of a subjective physical presentation. So again, while the physical exam, I'm not saying don't do it, and we all do it, but I would sort of understand the limitations of the physical exam, and at every opportunity that I have to find objective data to support what I'm doing, I try to do that. And whether that be with hemodynamics, with echo data, with something on which you could place some objective value, as opposed to the physical exam, I think that would really benefit you guys. And feel free. These are published data. So when you're attending, is really quiz you about the S3. You could say what's the sensitivity of that finding, and if it's 50%, then it doesn't really matter whether it's present or not. So what are key precipitants of heart failure exacerbation? We spend a lot of time on this trying to grill patients, try to figure out why they came in. And I think it's fairly important to try to figure this out because some of these are potentially treatable, reversible, or preventable. And as there's a lot of attention paid to trying to reduce heart failure readmissions, it's important to try to figure out whether you could find what it is that's causing patients to be admitted in the first place. So what are kind of triggers? So salt and fluid indiscretion is a possible trigger. The data on this is non-existent. There have been a lot of trials, retrospective stuff, looking at salt intake. There's really no data that excess salt intake contributes to heart failure exacerbations. A lot of the recommendations about salt intake in chronic heart failure have actually changed recently to be a little bit more relaxed. So what we try to tell patients to avoid salt, and probably a very salty meal, so very high salt intake is probably not good for you. It's not really clear that French fries alone is enough to put you into heart failure. Medication noncompliance is extremely common, especially with diuretics, concomitant medications. So not corticosteroids as much, but NSAIDs, which are associated with a lot of sort of bad things: hypertension, worsening renal function, ischemia. They interfere with aspirin effectiveness in people with coronary artery disease. So we frequently see NSAID use as a cascade leading to abnormal renal function, which then will cause fluid retention, which then will cause people to be hospitalized. Concurrent medical illness, so having the flu, having something else, alcohol or drug use, worsening renal failure. If your primary etiology of your heart failure is ischemic, then potentially having angina will cause your heart function to decline in some way, or potentially cause some relaxation abnormalities and may lead to heart failure. Valvular abnormalities, so either acute and chronic worsening of aortic stenosis, aortic regurgitation, or mitral regurgitation may do this. Clearly, if somebody has endocarditis or an acute valve lesion, it's quite likely to present with heart failure. High output heart failure is exceptionally rare. Arrhythmias, right? So somebody who is normally in sinus rhythm all of a sudden goes into atrial fibrillation with a rapid ventricular response may come in with heart failure. Hypertensive emergency, so somebody with blood pressure acutely rises, potentially that's a problem. Or things like myocarditis, stress-induced cardiomyopathy, other things that to cause acute heart failure. Some more data. So arrhythmia. And these are potentially, you could have, multiple. So arrhythmia, hypertension, ischemia, you can see some of these things. The majority of patients, or, a significant percentage of patients have none of these, right? So we don't have a clear source. And it's okay not to have a clear source. So it's okay to tell your attending, I asked about some of these things. None of them were obvious. I'm not really sure why this patient went into heart failure. That is sort of an acceptable answer. So what's useful testing? So you see somebody in the emergency room calls and says, this Mr. So-and-so, has rales, hypertension, shortness of breath, and they have known heart failure, so come fix them. So the question is, what kind of things do you want to think about in terms of initial evaluation that will potentially help guide management? So in patients who are known to be ischemic, or there's some suspicion that they may be ischemic, an ischemia evaluation is reasonable. So it's reasonable to check an EKG for obvious things, including arrhythmias, as well as to check a troponin. A lot of patients with heart failure, especially patients with chronic systolic heart failure, will have chronic low-level troponin elevation, so a troponin of 0.1, 0.2, 0.5 in the setting of acute decompensated heart failure is not at all uncommon. That's not really an ischemic event. Whether you're ischemic or not ischemic, you're equally likely to have those troponin elevations. So what this means is that you shouldn't, what this means is that ischemia should not be the default diagnosis when you see somebody in this situation. The default diagnosis is probably a troponin leak from heart failure, although clearly somebody can have an obvious ischemic event. But in the absence of an obvious ischemic event, the majority of these patients are not going to need to go to the cath lab or have acute coronary syndrome management directed at them early, meaning get Plavix, heparin drip, and IV beta blockers and these kind of things. So potentially those things could be pretty detrimental. Getting routine labs is important. Liver function studies we talked about, potentially lactate if you're concerned about hypoperfusion. BNP, I'm not a huge fan of, for a number of reasons. I think the best role for BNP is to try to differentiate heart failure from non-heart failure. So if somebody has COPD and unclear heart failure diagnosis and they come in short of breath and they have sort of some vague findings, if their BNP is low, that probably means the hospitalization, that patient is primarily having a pulmonary event, but it is quite likely that patient's BNP will not be low. They will be either intermediate or elevated, because in the setting of renal dysfunction, hypertension, other things, the BNP could be elevated for a variety of reasons. And then BNP could be falsely low. So obese patients will have a falsely low BNP. So there's a lot of things that the BNP does not provide you with. I also want to stress that an elevated BNP does not imply that the patient has either severe volume overload or heart failure. We see plenty of patients whose BNP is in the thousands, which is a chronic finding and for who extra diuresis would not be of value. So we do not diurese the BNP alone. I'm not sure if you guys are using the NT-proBNPs here predominantly, but I think that people are transitioning to that. Partly is because Entresto, the new heart failure medication that was approved, will raise BNP levels as part of its mechanism of action. So as more and more people get on that, checking their BNP will no longer be accurate, but their proBNP is still accurate. A chest X-ray is really reasonable to check for, to document congestion if needed. So what about a SWAN? So that ESCAPE trial that I mentioned, which randomized patients, did not show a benefit. It was completely neutral. So the vast majority of patients will not need SWAN-guided care, and I really would not think about that at all. I would sort of manage patients, without a SWAN. There are some circumstances in which SWAN-guided care is useful, or obtaining a right heart cath in the cath lab is useful, and we do that very frequently on the heart failure service. So for you guys, I would say that if the cardiologist and nephrologist disagree about diuretics, your options are to generally listen to the cardiologist, but if there is a disagreement, just get a right heart cath. So it's pretty straightforward. If there's disagreement, meaning the cardiologist says this person needs diuretic, the nephrologist says this person needs fluids, just get a right heart cath and be done with it. The vast majority of the time, the cardiologists will be right. If you have true suspicion for a cold profile, so if some of those things I mentioned are true, the lactate is high, the LFTs are high, the patient is nauseous, those patients should get early right heart cath to try to really figure out what's going on. But we know that routine guided care is really not beneficial in pretty well-designed clinical trials, partly because sometimes it's hard to know what to do with the information. Sometimes we'll use our clinical intuition more so than the significant amount of data that could come from having a SWAN in place. So what about the role of echo? So what kind of information do we get on an echo that's potentially useful in the setting of heart failure? So we get a few things. So an echo will provide you with systolic function of the left ventricle and the right ventricle. Don't forget that heart failure, although the presentation is different, can result primarily from a right ventricular failure episode in the setting of a pulmonary embolism or something else. So those patients typically will present with things like edema and abdominal distension, but in the absence of pulmonary edema, because the right side is obviously before the lungs. So the echo will also provide evaluation of valve function. We talked about aortic stenosis, mitral regurgitation. Those are things that are potentially useful to know if you're managing heart failure. If somebody has a new wall motion abnormality, that could be suggestive of ischemia, so that could be useful to try to figure out early. Extracardiac condition, so what if for some reason it's a cancer patient and they actually have pleural effusion and they're actually in tamponade, or pre-tamponade is the reason of their heart failure. That's something that you don't want to miss. Occasionally you'll get information that's surprising about the etiology of heart failure. So there are some echo findings that are suggestive of cardiac amyloid, and then hypertrophic cardiomyopathy and constrictive pericarditis are things that you could potentially diagnose on an echo. The thing that I really want to stress that I find extremely useful in the management of heart failure patients, both on the inpatient and outpatient side, is to evaluate their IBC with an ultrasound, right? So echo, so the sonographers here, more so than Jewish, will routinely look at patients' IBC and will do a good job trying to look at their IBC. Based on the size of the IVC as well as collapsibility with normal respiration, that correlates fairly well to cath measured right atrial pressure, and that's really your target of diuresis in heart failure, and that's really your evaluation of volume status, right? So this is obtainable. There's not a lot of data on using this in heart failure, but there's some. So 90% of the time, you should be able to obtain an IVC evaluation, even in obese patients, if you try hard enough. And so sometimes, if the cardiologist and nephrologist are arguing, you could just get an ultrasound and look at their IVC. If their IVC is dilated and there's not a lot of respiratory variation, that patient is volume overloaded and needs diuresis, and you do not need any invasive or expensive ways to document that. And with the limitation of JVP and physical exam findings, I think this is a very easy to measure objective sign of right-sided filling pressures. I would encourage you guys to get comfortable with using the ultrasound. I'm not sure how available portable ultrasound machines are here, but I'm sure the MICU has one. The CCU, I don't know, may or may not have one. But go ahead and grab it and look. It's free. It's really easy. The cardiology fellows should all know how to do it. But honestly, I could teach anybody here in 15 minutes how to do it, and you just have to try it on like 10 patients to get fairly comfortable with it. It is very, very simple to do. Much simpler than looking at somebody's JVD. I mean, looking at, JVD evaluation is difficult physical exam finding to learn. This is an easy physical exam finding to learn, and I use it very, very frequently. Evaluation of diastolic function. The reason I have a question mark is, diastology in general, as a field is evolving and has evolved significantly. What used to be called diastolic heart failure is now called heart failure with preserved ejection fraction, partly because we don't have a good way to either measure diastology, and we have for sure no way to treat or target diastology with medical therapy. So the role of knowing somebody's diastolic function on echo in the setting of heart failure is really, really unclear. Just because there is a comment on diastolic dysfunction or there's no comment on diastolic dysfunction does not mean one way or the other that the patient has heart failure with preserved ejection fraction. Okay, so that is probably different from what you have heard. So, but for sure there is excellent trial data now from multiple trials to support this. There is no correlation between diastolic evaluation on echo, essentially, and heart failure with preserved ejection fraction. So those two things are fairly different. There's some use for diastolic parameters to help guide evaluation of left-sided filling pressures in these patients, but that is a little bit more difficult and really is only useful on the extremes. And so in patients who have grade 2 diastolic dysfunction, which is the majority of patients with heart failure, that is not useful one way or the other. So when to order an echo in the setting of heart failure? So while I think there is typically an impulse when you see somebody with heart failure to get an echo as like the first thing, I'm not really sure that it's needed or helpful. I would suggest an echo if there's no recent echo available. If somebody had an echo 3 months ago, I would not rush to order an echo unless you have specific reasons why you feel that may be of value. If for some reason you think there's a new murmur and you think that a new valve condition like a ruptured valve or previously undiagnosed aortic stenosis, you could potentially order an echo. This is fairly rare. If patients are not responding to treatment, they should get an echo, or if the volume status is unclear, to evaluate their RVC. I think that is useful. Routine echoes in patients who have known either systolic dysfunction or have normal systolic functions, have preserved ejection fraction, are not likely to change your management acutely, and I think are not particularly useful. I would much rather, if somebody comes in with particularly with systolic heart failure, and they have an echo from 6 months ago, and I know the ejection fraction was 20%, I could assure you it's still 20%. I would much rather know what their heart looks like, what their valve function looks like when they're diuresed, or when you think you've reached optimal filling pressures, or if there's a clinical question, than to know what their echo looks like when they're acutely decompensated, because that echo is going to look worse for a variety of reasons. The heart will be larger, you'll have more valvular regurgitation. Most of that should get better with diuresis. So knowing what their echo looks like closer to baseline, as well as documenting that their IVC is now normal, I think it's much useful than rushing to get an echo early on in that hospitalization. And again, knowing the patient's diastolic function is very unlikely to change management in the acute setting. And so I definitely would not look for that as one of the first things that you look for. Like, you look for systolic function. You look, oh, does this patient have low ejection fraction, and does this patient have diastolic dysfunction? Those two are really not at all similar. Where, you know, systolic dysfunction is useful to know about, diastolic function is much less useful to know about. So how does decompensated heart failure occur? This is probably another area where I think there's probably a lot of misconception about heart failure, how heart failure occurs. My guess is, if I were to ask you guys what leads to decompensated heart failure, you would say, well, the heart doesn't pump well enough, there's a backup of fluid into the lungs, and therefore you get congestion. So that is predominantly not true. I would say that probably 1% of the heart failure that you will see in your training occurs via that mechanism, and predominantly there are other mechanisms involved. So this is fairly well described over the last few years only. And so people describe sort of two main pathways to try to get to acute decompensated heart failure. And again, so when I say acute decompensated heart failure in this situation, I mean central congestion. So shortness of breath, rales, elevated filling pressures in the heart. That's what I mean. And so the question is, how does that happen? So the two mechanisms described, the slow one is potentially one where you, over time, will retain fluid, your cardiac output is potentially low, that increases your effective circulatory volume, and that leads to congestion. The more likely pathway is this fast pathway. And so the way that you know this is because you could ask most patients in the emergency room, when did your symptoms start? And they'll say 3 hours ago. Right, so I could assure you that it was not that 3 hours ago their cardiac output went from normal to low in that second, and it caused them to have symptoms. Something else happened over that short period of time to cause them to have symptoms, and this is what it is. So the vast majority of your guys is sitting here. Blood volume is actually not in the effective circulation. It actually hangs out in venous capacitance vessels. So in your lower extremities, in your splanchnic vasculature, about 70% of your blood volume is actually just hanging out, sitting there in high capacitance, vessels. So when you have some precipitant that increases your sympathetic activation, whether that be a little bit of volume overload, a little bit of ischemia, and arrhythmia, really anything, that causes sympathetic activation, which causes redistribution of fluid from peripheral circulation into the central circulation. And so patients with heart failure are not really able to handle that significant increase in their main circulation volume, and that's what causes them to go into pulmonary edema. So essentially, instead of having chronic slow volume overload, what you have is a fast redistribution of volume from venous vessels into the central circulation, and that's what causes congestion. And so if you think about it, that really potentially will affect how you treat people, because it affects both the underlying, pathophysiology of why this happened. But, if you're not actually holding on to a lot of extra fluid, but you have fluid that shifted from one area to another, then perhaps the way to fix it is to shift it back, as opposed to try to, diurese it away. So do patients gain weight prior to their hospitalization with heart failure? And the answer is not really. So while this paper that was published in Circulation essentially says patients gain weight prior to their hospitalization, and the amount of weight that they gain, it's in the order of pounds, right? So these are patients who were hospitalized versus patients who were not hospitalized, and the days prior to their hospitalization. So yeah, this looks clearly statistically significant, but this is a change of 2 pounds. So that's like whether you had a bowel movement or not that day, So this is very, very minimal and very difficult to detect in individual patient weight fluctuations, which again suggests that potentially there are other mechanisms such as redistribution that are playing the predominant role in the management of heart failure. You could see that most patients gain less than 2 pounds. So that's not really consistent with significant weight gain prior to heart failure admission. And while we do tell patients in heart failure clinic to weigh themselves, every day to monitor whether they're retaining fluid, it's really that strategy has not really been shown to be effective. And partly, this is the reason. It's because weight gain could be very, very minimal in patients who present with heart failure. So this is stuff that's statistically significant, but not clinically significant. This is another chart to compare the two mechanisms, only here instead of labeling them fast and slow, they label them as central and peripheral. So central is the one that I think is what's mostly taught in med school, but the one that's much rarer. So this is reduced cardiac contractility, people will gain weight, it's slow, people have fatigue, which is again suggestive of low cardiac output. Again, the majority of patients, I told you, present systolic blood pressure in these patients is normal or low, which is why I said in the beginning, if you see somebody with acute decompensated heart failure with a low or normal blood pressure, that really should raise potentially some alarm bells, especially if the blood pressure is low. This mechanism is the one that much more closely fits with the patient characteristics I showed you early, which is the hypertensive patient. So this is the increase in afterload. There's no gain in body weight. It's rapid. Shortness of breath is the main symptom. Systolic blood pressure is usually high in the situation, as is the cardiac output, usually normal in this situation. So I would say that the warm and wet profile of heart failure, which is 90% of what you see, is this mechanism, so primarily redistribution, whereas the cold and wet profiles of patients who are in cardiogenic shock or approaching cardiogenic shock is predominantly these patients. But again, the vast majority of patients, based on how they present, are presenting with normal cardiac output, hypertensive, with redistribution being the main mechanism. So what does that mean for treatment? I did mention that trying to figure out the underlying etiology is useful, and I think it is useful because if somebody comes in with AFib, with a rapid ventricular response, then targeting therapy to that is potentially, with an early cardioversion or at the very least rate control is potentially useful. Patients who come in, anemic, who come in after cocaine use, who have active ischemia, those are precipitants of heart failure that are specifically correctable, and I think should be corrected. Other than that, diuretics remain the mainstay of therapy. But, as I mentioned, if the predominant mechanism is likely redistribution, then managing patients for that redistribution is likely to be particularly useful. So what you want to do is you want to manage preload and afterload, right? So afterload, really the easiest way to think about it is the systolic blood pressure. So how do we do that? So vasodilators, things that reduce blood pressure, that reduce afterload. Nitrates will do that. Hydralazine will do that, particularly oral. IV hydralazine is really not a medication that anybody should be using anymore. Nitrates, so nitrates reduce afterload. Potentially nitroprusside, so nipride in patients who are sicker will reduce afterload, and is an exceptionally effective management for decompensated heart failure. Vasodilators, things that reduce preload, are also effective. So things like nitrates or morphine. So morphine will also, not only is it a preload reducer, right, but it quiets your sympathetic activation. So if that's a predominant mechanism underlying pathophysiology, then controlling that sympathetic activation is exceedingly important. CPAP, right, is a... Yeah.
Can you repeat the hydralazine?
Yeah, so IV hydralazine is not really a medication that anybody should be using these days. There's a number of reasons for it. One, it is exceptionally short-acting and rapid in effect. So if you want to make the numbers look good for your attending in the next 5 minutes, then hydralazine works well. But in terms of what's going to happen in half an hour, and in terms of what's going to happen to the patient's hemodynamics in that 5 minutes, I think you have to be really careful. So in anybody with coronary disease, IV hydralazine is actually contraindicated because it increases O2 demand. So by dropping blood pressure acutely, there's the risk of causing reflex tachycardia, which will increase O2 demand. So in the setting of significant coronary disease or ischemia, that's a definite no-no for IV hydralazine. But even in patients with heart failure, using a medication that starts acting in minutes and potentially is gone within several minutes after that, I think is not beneficial. I think using oral hydralazine, which also has a short onset but has a much longer duration of action, is more beneficial. So doing things that are using medications that are very short-acting are good for emergencies, like using adenosine to treat supraventricular tachycardia, right? Very short-acting medication, you're using it for an emergency, it's gone in 30 seconds, perfect. But using very short-acting, powerful medications for patients who are potentially sick, the effect of blood pressure and who you don't know what the response of the blood pressure will be to that in that patient, I would really avoid IV hydralazine in essentially all circumstances. There's much better medications to use, whether it's PO hydralazine, IV nitrates, IV labetalol if you need that in other settings. Really, IV hydralazine is not a good medication. CPAP is an effective preload reducer, so it could be used in an emergency setting. And then I do want to stress, continuing their baseline medications. So patients who are on beta blockers, who are on ACE inhibitors, who are on other things really should have those medications continued during the heart failure hospitalization, unless there's a significant reason to not continue them. So again, because redistribution is the mechanism, trying to ease that redistribution by correcting their preload, correcting their afterload is the way to go. Note that none of these things address contractility, right? So when you treat patients with heart failure, my guess is, you haven't seen a lot of patients who are getting inotropes for acute heart failure, that what we're treating is essentially preload and afterload. We're really not treating patients' contractility, and that works well the vast majority of the time, which suggests that patients' contractility is not the primary mechanism of their heart failure exacerbation. So some additional treatment thoughts. If redistribution is the predominant mechanism, right, what that suggests is that these patients have not really gained weight. They don't have a ton of extra volume on board. So it's pretty easy to over-diurese them. So especially patients with heart failure with preserved ejection fraction, like the little old ladies, they'll have a pretty narrow therapeutic range in which they do well to either avoid hypervolemia or hypovolemia. So significant diuresis is sometimes not the right step as the initial management in these patients. And really, you could get a lot done in a very short period of time in the emergency room by using this therapy. One other comment about nitrates. I much prefer IV nitrates and nitro drip. In this setting, oral nitrates are probably better than nitro paste, right? So nitro paste or patch are things that with unclear dosing, unclear absorption, and so I think if somebody's sick enough to be in the hospital, they probably should just get the nitro drip that's easily titratable, and you know what the absorption is. And when you stop it, you know it's gone, as opposed to the nitro paste or patch, which 7 days later, when the patient's about to get discharged, you're like, oh, that thing is still on you. Oops. So I think using IV medications is much preferable. Inotrope therapy, I think, is rarely needed in management of acute heart failure, and I would really suggest trying to get some estimate of patients' cardiac output to confirm that it's low before you use inotrope therapy. Remember, inotropes in general are associated with increased mortality. So before you use a medication that's associated with increased mortality, you really need pretty good documentation that that medication is likely to be beneficial. So while some cardiologists will start sort of empiric inotropes, and we do it, once in a while based on our experience, it's quite useful to get some estimate of cardiac output to confirm that that's needed, whether that be swans. I don't know if you guys have FlowTrack, which is like a non-invasive blood pressure cardiac output estimator. There's also ways to estimate cardiac output on echo, which I think is quite effective actually. And I think cardiology fellows, or if you order an echo specifically with that question, then the sonographer will try to do a better job to address that question. And then you could always, if you are specifically looking for it, you could go and review the echo and have that attending comment on what they think the cardiac output is. There's a few ways to try to estimate it. We don't routinely report it on echo because it's generally the images, and the images that are acquired are typically not acquired for that purpose in routine studies. But if that is is a clinical question. I think echo is quite useful in estimating cardiac output, especially it could be say, it's really, really normal, it's really, really low, or I'm not sure. And really knowing that is pretty important. Always give us a call if you see things like, if the liver function studies are rising, you guys should really be calling somebody with some experience in managing heart failure, because that's potentially very serious. A comment on intra versus extravascular volume, right? So low extremity edema is extravascular volume, and so a lot of people have low extremity edema, which does not necessarily mean heart failure. So you really need an evaluation, whether that be by IVC evaluation, JVP, invasive hemodynamics, of what somebody's intravascular volume is, because that's really the space from which you could diurese. If somebody has low extremity edema because they're obese, or they have chronic vascular insufficiency, or they have really low albumin, all of those are possible where you have very volume overloaded patients with total body volume overload, but very low intravascular filling pressures. And those patients are exceedingly difficult to manage and diurese. So low extremity edema is really should not be your only target for diuresis. So what about, I know I only have a few minutes left, but what about diuretic dosing? So there's been a bunch of trials about high dose diuretics, low dose diuretics, whether diuretic drip, so Lasix or Bumex drip, is more effective than bolus diuretics, so giving diuretics IV 2 or 3 times a day. And really the trials really suggest that whether you use, this was a 2x2 design of whether you get continuous drip or you get bolus, and whether you get low dose or you get high dose of diuretics. And really, the outcomes here are pretty similar. Overall, any of these therapies are effective. They don't really affect length of stay, decongestion, or other significant outcomes. You may have a little bit more weight loss with high dose diuretics and low dose diuretics, but potentially you could overshoot and have worsening renal function in these patients. I would say any strategy is reasonable. My suggestion is to double their home diuretic dose and do that as IV or as IV BID to TID dosing. So if somebody's on 40 milligrams of Lasix once or twice a day, I would do 80 milligrams IV, BID, or TID. That's usually a reasonable place to start. Does adding dopamine help? No, don't do it. There's good randomized data to suggest it does not help. Should beta blockers be stopped in acute heart failure? No, they should not. There is trial data to support this, both retrospective and prospective data. Acute cessation of beta blockers is physiologically similar to inotropic therapy, which we know is bad for you. Acute cessation is associated with rebound sympathetic system activation, which I said is one of the mechanisms of causing that patient's heart failure. You could precipitate angina and arrhythmias, ventricular or supraventricular arrhythmias, and there's randomized data to confirm this. So beta blockers really should be continued unless patients require inotropes. And again, the majority of these patients are hypertensive. There's really no reason not to continue beta blockers, but beta blockers should be continued generally at the same home doses during heart failure exacerbation. What are endpoints for effective diuresis? It is hard to know. There is surprisingly not a lot of data on this, but I will point to this one trial. So they looked at predictors of readmission in patients, and it was specifically focused on ultrasound assessment of the IVC to see whether or not that could be a predictor. So they looked at all the normal comorbidities, demographics, and none of those predicted whether or not patients were or were not readmitted. Notice that in the study of 75 patients, 31 were readmitted within a few months. So heart failure patients have an exceedingly high rate of readmission. So at least a third at 6 months, if not much more, will be readmitted. So there's a lot of emphasis on how to prevent readmissions. So at discharge, log BNP, but not BNP. So you're like, that's a statistical manipulation. Was statistically significant with readmission, but so was the IVC size. So if you, for those of you who are not familiar with IVC measurements, so 2 centimeters or so is the cutoff, where if somebody's IVC is above 2 centimeters, you suspect that they still have elevated filling pressures. Under 2 centimeters, potentially not, as well as IVC collapsibility index. This is whether or not you have a 50% or, and the cutoff here is whether you have a 50% or more change in the IVC during the respiratory cycle. So if you do have a change of 50% or more, that suggests that you have normal filling pressures. If your IVC does not change with respiration, that suggests that you still have high filling pressures. So these things were very statistically significant on discharge to predict whether or not you will or will not be readmitted. In my opinion, everybody should just walk around with an ultrasound and to confirm what patients' filling pressures are, and that this is really a requirement on discharge, to confirm that you actually got patients to normal filling pressures, whether that be through diuresis or reversal of their sympathetic overdrive. Regardless of the mechanism, if you are discharging somebody who, based on these numbers, their right atrial pressure on average was still in the 10 to 15 range, those patients will not surprisingly have a very high rate of being readmitted. Questions? Yeah.
So I think you mentioned this earlier, but you mentioned, so if you have a patient who you suspect is in acute decompensated heart failure, but they don't really look too intravascularly overloaded, so would you still trial diuresis in them first, or focus on like another strategy like after?
So when you say they don't see volume overloaded, is that because you know by some objective measure that they're not, or you're just going based on physical exam?
Just physical.
Yeah, so it's hard to know. So it's really easy to miss intravascular volume overload, right? And there is some data, both on inpatient and outpatient side, again, that I think that you know, when you have somebody evaluated by a cardiologist and then you have somebody look at their IVC, and you see that there's quite a big discrepancy between what the cardiologist thought and what their actual filling pressures were. So when in doubt, I would just look at their IVC. I think if somebody's really hypertensive, I would probably correct that first. If somebody has an arrhythmia or some other reversible cause, I would correct that first. But if somebody's short of breath and other things are not quickly working, I think that probably will require some diuresis. It also depends on how much extravascular volume they have. You know, if somebody has a lot of extravascular volume, then you have more room for error because even if they're not intravascularly very volume overloaded, you will shift some of that extravascular volume into the intravascular space with diuresis, which will prevent you from over-diuresing somebody into, you know, acute kidney injury. But I think, you know, sometimes, you know, it's not easy to tell what somebody's filling pressures are. You know, I think, you know, we've rounded together, and I'm not sure how often I've used ultrasound when we were rounding, but I think I use it a lot. And if I had one available in clinic, I'd use it on, a significant percentage of patients. Yeah.
So we know sympathetic overdrive plays a pretty key role in chronic heart failure, some role of beta blockers. I know you talked a bit about how that is also involved in decompensated heart failure.
Right.
Does this understanding of this mechanism change how we should be using beta blockers?
No. I think that the beta blocker, the chronic. So what this shows is that you could still overcome the beta blockade with through sympathetic activation. Right? I mean, these patients still have a fairly normally functioning sympathetic, nervous system, and regardless of how much beta blockers you give somebody, if you give them enough, dobutamine or other sympathetic drivers, you'll still make them hypersensitive, make their heart rate high. So I think the acute and the chronic management in the situation are different. You know, in the acute situation, it's really easy to reverse that sympathetic overdrive quickly with afterload control, with correction of the underlying pathophysiology, with things like morphine and nitrates. Because remember, so one of the causes for sympathetic overdrive in acute heart failure is dyspnea. That is a significant driver. If you imagine yourself being short of breath, that really is a significant driver of the sympathetic nervous system. So by correcting the dyspnea, so by reducing preload with nitrates, morphine, these kind of things, that significantly will reduce sympathetic drive. So it's it's kind of like a circle one way, where sympathetic activation leads to pulmonary edema, which leads to dyspnea, which leads to more sympathetic activation, right? So that's a circle in one way, but then the circle in the other way work the same. That once you start correcting one process, the other drivers get better, which helps correct the process quickly. This is why sometimes, some people come to the emergency room and literally like 3 hours later they're back to normal with a little bit of morphine, a little bit of nitrates, and some BiPAP. So that's not. I'm sure all of you guys have seen that. That is fairly common. So.
I saw somebody with this one earlier this month. And so I'm kind of curious as to, in studying people who have acute decompensated heart failure and studying chronic kidney disease and what is an appropriate? I mean, after at some point it goes to the floor, you can't have really access there, volume. So how do you? What's the
So stepwise approach, right? So interpretation of SWAN data, I think, is sometimes confusing to people who don't interpret SWAN data often. So I think you definitely need some cardiologist who's quite experienced to interpret, SWAN data. So what's useful in the SWAN? So it's useful if you put a SWAN in, their wedge is 25, their cardiac index, let's say, is 2.5, which is right normal adjusted for BSA. So you're like, okay, well, that person's pretty straightforward. They just need diuresis. They don't need anything else, right? If their wedge is 25, their cardiac index is 1.2, you're like, wow, that patient probably will not respond to lasers because their heart's really not working. That's a patient who really does require diuresis. So, I think those episodes are pretty simple. I would say that in general, you should ignore, once you have a SWAN in place, you should essentially ignore renal function when it comes to how you're going to diurese a person, because then you actually know their hemodynamics, and so the renal function becomes much less important. The data on renal dysfunction in setting of acute heart failure is kind of conflicting. There's some data that, whether or not your creatinine goes up or does not go up during the heart failure hospitalization, you're probably likely to do the same. There's other factors involved. I do have to say that, so why does renal function get better with diuresis? Can somebody give me like a quick answer to that? Like, we see patients come in with acute decompensated heart failure, with low cardiac output or normal cardiac output, whose creatinine is 3. They get diuretics and their creatinine gets better. Why does that happen? Because that's not what you were taught in medical school, right? In medical school, when somebody, or even in the emergency room, right, when somebody has elevated creatinine and low blood pressure and they're in heart failure, they must be dry or pre-renal, and we should give them more fluids to try to get that creatinine better. But we all clinically see when you manage a lot of heart failure patients that creatinines get better with diuresis. And the question is, why does that happen?
It's a shift in the fluid, so you get more infusion.
So renal perfusion, so tell me, what do you mean shift in the fluid? Why do you get more renal perfusion?
Well, as soon as there's a shift in, like you're diuresing off.
Your treatment, right, has to explain why things get better. So unless you're targeting a specific pathophysiologic mechanism, right, if you're not targeting, that's not the mechanism, right? So. Okay, so how does that help?
So it dilates the renal arteries, so you have increased perfusion pressure.
Good theory, but no. That is for sure not the mechanism. In like 99% of patients. Yeah. Okay, so this is a slide. There's a lot of data, both from the ESCAPE trial and others on this. So this is prevalence of worsening renal function during the hospitalization. Okay, so blood pressure. So worsening renal function percentage and the blood pressure. This is pretty flat, right? So blood pressure does not play a role. What about filling pressure? So wedge pressure, left-sided filling pressures. Wedge less than 20, wedge greater than 30, no role. Okay? So cardiac output. This is actually a little confusing in this trial, but essentially what they showed is that you had more worsening renal function in patients with better cardiac output than worse cardiac output. But essentially, depending on how this paper has like a paragraph explanation about why this is the case, because this clearly does not make any sense. But and essentially, their conclusion is that cardiac index is not the determinant of renal dysfunction in patients with heart failure. And the way that you know this is because none of the treatments for heart failure that I mentioned, I said we should avoid inotropes, right? So none of the other treatments that I mentioned specifically improve cardiac output. So if you don't improve cardiac output and your renal function gets better, that means that it was not low cardiac output that was predominant determinant of your renal dysfunction. So what in all trials comes up as the most significant is CVP. So right-sided filling pressures. This is essentially renal afterload. So your renal perfusion pressure is the difference in the pressure gradient between the systolic pressure, so the pressure going into the kidney versus the pressure that's coming out of the kidney, right? So by having a very high pressure coming out of the kidney, you're decreasing renal perfusion pressure. And so this is the reason, this is by far in all trials the biggest determinant of worsening renal function. You could see that you could discriminate between essentially 0% and almost 100% certainty that you will have renal dysfunction during their hospitalization based on their CVP. And this is the reason that renal function improves with diuresis. It's because you're decreasing the CVP through diuresis or through shift into the peripheral circulation or whatever mechanism. And by reducing that CVP, you're reducing renal afterload, you're reducing venous congestion, and that's why renal function gets better. So this is totally explainable by the pathophysiology that I described earlier, as well as completely supported by trial data. Also in the ESCAPE trial, the only determinant of worsening renal function was CVP. The cardiac index was not at all a determinant. Now that's not to say, and I mentioned earlier that worsening renal function is one of the signs of a cold profile, and we clearly see that hypoperfusion, whether that be to the kidneys, to the liver, will cause worsening renal function. It's probably only at cardiac indexes. There's some data to support this of 1.5 or less. That you're likely to see significant renal hypoperfusion from a forward flow standpoint, and still in those circumstances, predominantly the renal afterload, so the venous congestion, that's the driver of worsening renal function. So that's the long answer to renal dysfunction in this setting. But this is the answer to why renal function gets better with diuresis.